If you're going to vaccinate your children against COVID-19, I think you ought to know what the risks are. In this episode of One Belly, Two Brains, the CDC releases brand new information about myocarditis, which hadn't been discovered in adults in the same kind of numbers, and so now has to be added to the emergency use authorization. And so in this episode of One Belly, Two Brains, I'm going to go over the CDC's own data from the Vaccine Adverse Event Reporting System and VSafe, their online mobile app, and the new thing they discovered with myocarditis, which is a inflammation of the heart. So myocarditis is something that's a really serious side effect, and they didn't see this in other vaccine trials that they did. They analyzed the 8.9 million kids aged 12 to 17 who received 2 shots of the vaccines for COVID, so Pfizer and Johnson and Johnson. And what they looked at was the number of people who reported some kind of adverse event. That number was around 9,000. They saw that 90% of them they considered to be non-serious events. These are things like headaches and fever and fainting. Fainting or syncope or vasovagal responses, they said were really common in teenagers who get vaccinated anyway. And so although it combined was about 25% of all the kids, they weren't overly concerned about that because they seemed to recover fine. The kids who had more serious adverse events had something that they called myocarditis. And so there were a lot of children who were showing different signs and symptoms that they lumped together into the same diagnostic criteria. They reported that was close to was between 4 and 5% of the children who reported in VAERS and also in the ones who self-reported that this was a problem. Now, the self-reporting thing and VAERS, both the CDC says are likely the unreported numbers. The chances of them being accurately reported is probably better in VAERS because part of the emergency use authorization mandate is that all visits to the hospital, healthcare providers, all are supposed to report those kinds of adverse events. The self-reporting thing was something that they wanted to help improve the ability for people to report that stuff on their own. And so they came up with VSafe a couple of years ago in order to start tracking that kind of data. Now, one of the things that they were looking at here was whether or not this was present in other trials. And they did find in surveillance data that things like myocarditis were an issue. Makes a lot of sense. So the COVID-19 spike protein itself is exceptionally, like in the high 90 percentiles, has an affinity for a receptor inside a lot of blood vessels and in a lot of heart tissue and a lot of kidney tissue for this hormone called ACE2. And ACE2 is a receptor that usually the hormone that gets released by the kidneys helps to lower your blood pressure. So if your body's creating spike proteins based off of the mRNA vaccines, and that's floating around someplace inside of your body, which it's not supposed to do, but apparently does, then it has a really high likelihood of meeting that tissue and sticking into it. If it does meet that tissue and sticks into it, then that's where it starts to cause inflammation. When it starts to cause inflammation, remember, is caused by your immune system's reaction and attempt to dissolve whatever that stuff is. So what they saw inside these kids gave them enough pause to go ahead and say, all right, apparently what we need to do is amend the criteria for the emergency use authorization to let people know, and this was again, early August, this trial has been going on since last year, to let people know that this is a possibility. So this is what doing the science in real time looks like. If you are going to have an emergency use authorization for something that's going to potentially be a life-saving measure, they say that if you're going to make an omelet, you got to break a few eggs, and you got to figure out in real time, because we've never used this kind of technology before, what the side effects are going to be here. Now, in terms of relative risk, what they saw was that it was 1 in 1,000 kids who ended up with an adverse event. So if you think about your average high school size in America, somewhere between 1,000 to 2,000, you're gonna have at least one kid who has, 90% of them are going to have something that is going to be what they're going to consider a non-fatal reaction to this. It's not a huge number, right? Some of those kids are going to end up with a more serious reaction. It especially seemed to affect boys. And the average age for the boys that got affected with myocarditis was 15 years old. So again, looking at the numbers even deeper, it looks like in that population of children who got vaccinated, about half of them were white kids. So it was about 45% of the number of people that they looked at here were Caucasian. Now, a full quarter of the kids weren't identified by race at all. Another 13% of them were unknown. So when we're looking at the data here, because something I've said from like the very beginning of this, the ability to understand and universally apply some of these health statistics based off of a skewed racial population is going to be a little funny. It's going to get a little funky when we're looking at the numbers because we know that people have been responding disproportionately to COVID based off of several things. Race is one of them. Access to healthcare is another one. The ability to live in a place where you've got plenty of space is another one. If we're looking at overcrowding, are people stacked on top of each other at schools? You know, if they're stacked on top of each other in their apartment buildings, if they're stacked on top of each other on the subway, right? That is going to have a very different impact than if you live out on a farm in rural Iowa and work outside during the summertime and you get plenty of vitamin D is able to penetrate through your skin because you don't have a ton of melanin. So as we're looking at all these different cofactors, again, it's really important to look at the data itself and say, is this universally applicable to everybody if they're going to make universal recommendations to everybody? So as you're looking at this and you're trying to figure out, hey, listen, is my kid at risk? Is this something that when Pfizer rolls it out, now that it has FDA approval, is this something I'm going to choose to do for my child? It's important that you know all the things that come with it. One of the things that's also important is something that came out from the Health and Human Services Department back in May. When they looked at comorbidity data on ages, and tried to put those things together for cities to be able to predict who's vulnerable in the pandemic, I noticed some really interesting things in their data. One is if you look at the cohort of children, right? So people under the age of 18, again, super, super low risk for hospitalization. Like we're talking 0% for people who have zero of the comorbidities. So we're talking about things like diabetes, heart disease, cancer, kidney disease, chronic lung diseases. These kinds of issues, when you have more than 2 of them in a child, increases the risk of hospitalization for that kid, up to 8% of the people who were hospitalized in that age group, or were in that age group with 2 or more comorbidities. But the number of kids who had one of those or 0 of them was 0. So as we're weighing risk reward, right? If you're looking just at the risk to your child for getting sick and dying from a disease, it's really important for you to understand what is the risk for us getting a bad outcome from the disease? What is the risk of my child for getting a bad outcome from having the inoculation? Every single vaccination that everybody ever goes through, I hope that this is a risk reward kind of calculus that they go through, because really it's up to you. Like you're the one as the parent that gets to enjoy the benefits of good health or suffer the consequences of ill health based off the decisions that you're making. And so that's really, really important to ask for good information, to read the inserts, to understand this. But prior to August, things like myocarditis were not in your insert at all. And this is what it looks like to do the science in real time. So now that we know that, then we can go forward and say, okay, let's study the kids who ended up with this problem. That's something that I'm really, really glad that our scientists are doing. It's something I've always advocated for. If we have kids who are obviously having some kind of problem with any shot, doesn't matter what it is, the thing that we need to understand about those kids is why. What made their bodies reactive to this? What made the conditions of their system create some kind of side effect that gave them a problem, and how do we help prevent that in the future? Or is it possible that that kind of stuff, if we can identify it, allows us to give those kids some kind of medical exemption so that we understand that we can actually help protect them from being able to have an adverse event? That's the kind of science that I like. That's the kind of science I think we ought to do going forward. It's really worthy research because it literally can save those kids' lives and not put them at unnecessary risk. So if this is the kind of information that you like to listen to or watch, then I bring this kind of stuff to you every single week. This is One Belly, Two Brains coming to you on Instagram TV. We do it on YouTube and also on Facebook, as long as we're allowed on those platforms. And don't get deplatformed like some of my friends have been recently. It's kind of ridiculous how when you're bringing CDC information to the public, you get a little CDC label slapped on your stuff. A little ironic, isn't it? Well, thankfully, because of these kinds of things, I'm going to be linking you to these CDC reports and Department of Health and Human Services reports so you can read the information for yourself. Until then, I'll see you guys all next week.